It's a huge honor, privilege, pleasure, however you would call it, for me to talk in front of you. I have to apologize for my English. It's not my native tongue, but I hope you can understand me in the whole seminar and webinar. Well, yes, I want to talk to you about the BD cuff implant system today. It's a system I'm familiar with over the last 3, 4 years because we developed something with this implant system for immediate molar situations and for all these indications we have for the BD cuff. And I'm trying it every day in my office. I'm using it every day in the office. And since September last year, I'm also back at the university. So I have the study part and the practical part on this situation. So I hope I can explain you a little bit and give you my the feelings I have and the enthusiasm I have with this system. But at the same time, I guess I will change a little bit today. Your point of view or your how you see implantology. I don't want to change your whole implantology, but I just want to add you an aspect, a new aspect to your daily routine, to your daily office practice doing placing implants. So let's start. Well, today I'm just concentrating on the soft tissue management, the emergence profile, and the gingival seal you can reach with the BD cuff and by using this BD cuff. And well, the first question is, what is an implant? And well, honestly, an implant is a foreign body that penetrates from the oral cavity through the soft tissue into the bone. That's an implant. This is the definition my boss at the university in Frankfurt gave me. And that's true. So that's nothing else. And maybe you can add, there is a tooth on it, an artificial tooth on it, but that's it. And before we go into the soft tissue part, I really want to highlight a little bit on the BD cuff itself. So it's a one-piece implant with a part which has threads and is treated on the surface. And you have a kind of machine polished part. And you see these little threads, or not threads, you see these little marks in the cuff. And these marks are just existing from the height up to from the height 4 and 6. If you have a cuff height of 2, they don't exist. That's a biological reason we will talk about later. And now you can see we have 3 different types of cores and diameters. We have different lengths of the tapered thread lengths or tapered thread part, and we have different parts of the machine height. And you can combine them adapted to the case of the patient. Something we already learned with the threads and the theory of threads with the Emergence system. So in this case here, you can adapt the size or the shape of the implant to the case of the patient. And yes, of course, the biggest difference is that if you see the defect, you can measure out your defect and you can say how much or how long is the defect, how much millimeters do I need to cover the defect with the polished part, and where is my part for the threads. So at the end, this is crucial. And this is where the soft tissue takes part, or where the changes of soft tissue treatment are taking place. And this is the important place where we're talking today. We're talking on this today. But often I get the question, what happens to the bone to the other side? For example, here to the lingual side or the palatal side. Is there a bone integration, whatever? And we looked at this question at the university also, and it's very simple. I don't want to cite Brannemarks. I don't want to go that far back in years to tell you that machine polished implants have been incorporated in the bone. There has been a connection between the bone and the implant. So this is quite usual for us, and this is quite normal. And there is an interaction. There is I would say, a contact between the surface, even the machine polished surface, and the bone. So the machine polished surface is not smooth as we expect. There's also a kind of roughness. And this was the reason why the Brannemark implants 50 years ago happened to work. So this is something you can rely on, that the bone on the opposite side of the defect, mainly it's the lingual or the palatal part, will take care of the implant, so to say. And the next thing we have to differentiate is, and if you listen to Dr. Park and when he's talking about the systematic, we have to distinguish between the implant bone and the alveolar bone, especially if you do an immediate implant placement. So everything which is for this primary stability or for covering the thread part is the implant bone. And maybe you remember that Scott Gans years ago created this term of triangle of bone, especially in the upper jaw. That means the bone is big at the base, and there's the thickness of the bone. And we have this implant bone, and we have the alveolar bone where the defect takes part. So for primary stability, the implant bone is crucial. The alveolar bone, or the alveolar part here, if you have an immediate implant placement, is more for the contouring. So we will highlight this in a bit. So this is how to place, for example, in an immediate socket, extraction socket, and the implant. So you can see that we calculated the defect height from the top of the lingual part of the bone until we reach the first covering, complete covering of the thread part. So you can see that we can calculate, and of course you can calculate this before if you use, for example, AutoGate or something guided. We'll see this at the end of the lecture. But this is very important that you have a smooth part going through the defect and you have the rough part covered completely by bone. So this is where the primary stability takes place, and this is where the osseointegration takes place. And of course, you're allowed to augment. It's not a problem, but this augmentation will not be for the osseointegration of the implant anymore. This is the big difference. So we do the augmentation just for the contouring. And at the university, the head of my department told us the BD cuff maybe is the first step for the democratization of implantology. That means even a non-skilled colleague can place implant because he doesn't have to augment that much, or he doesn't have to do the augmentation with the intention of a complete covering of the thread parts and to reach an osseointegration. This is not needed anymore because the osseointegration is taking part where you have the implant bone, so way deeper. We will cover this. You can cover this by augmentation material, or you can use some soft tissue graft, some gingival graft also. Depends on you, depends on your skills. We just need this, and you can see here the same. That's the same case where we gained this bone, even just by putting some bone material there, by the intention to contour the zone, and we call this zone of contourization, and this is the opposite of the zone of osseointegration. So that's very important to understand that the cuff part is something for the contourization and going through the defect so you can say cover the defect zone and not needed to be completely augmented to cover some thread parts. So that's the philosophy behind BD cuff, and I guess this is very important to know. But going back to the question we had at the beginning, the objective of peri-implant soft tissue is to seal the penetration. And this is very important because we reach the stability and the osseointegration in the inner part, in the bone, and now we have to seal the penetration zone. Now we have to seal the soft tissue because we don't want to have any infection there. So the question is how to do and what can we do? And looking into the literature, you can imagine, going back to the university, I love literature. There was in 2014, there was experimental study in humans, and they created some special abutments where they then did a probe and everything. And they recognized that there is, in this case, after 8 weeks, there are certain dimension of epithelium barriers and connective tissues, and there is something growing on the implant. The question is always, how much do we need? Is it possible? and how to protect and how to raise this soft tissue. Well, it was very important to see that also already in 1997, we can see in the study that there are some changes in after some months of loading or unloading implants, so that there is a kind of equilibrium, so that you will get some special or some certain depth for sulcus depths, junction epithelium, or connective tissues. So that's important. This is what we know, and this is something we want to imitate with natural teeth, even if it's not always possible because we're missing some anatomical parts compared to implants in bone. But this is something you have to keep in mind. And of course, everybody of you knows this wonderful study or publication by Ramon Gomez Meda, and the second one, he did how to say, version 2.0. And we can learn from this very, very easily. And this is very important for us to know, because looking back over the years, I'm doing now implantology. I started in 1997. That's quite a long time ago. Things changed. Diameters of the implants changed. Surfaces changed. Shapes of the implant changed. Internal, external connection changed. There's so many things which changed, and also the way we designed the crown on the implant changed, because we got a better understanding of soft tissue. And now, if you look how we can define this so-called EBC zone and how material should work, this is very important. If we use an implant like BD cuff, having a machined polished part of the cuff going through completely mucosa, and having only bone support on one side at least, or on the back side, as you can say, lingual or palatal. So that's very important for us to understand how the soft tissue is working. And if we look here, we have the C zone, connective tissue, we have the B zone with junctional epithelium, and we have the E zone, the sulcal epithelium. So these zones are different. And I would say we have to treat them different, and we have to use different materials. And this is very important, because if you're coming from a BD cuff implant, how to start? Is there something changing, or can we keep the soft tissue better? And the first thing I can give you as a take-home message, we will highlight this later if we talk about the abutment versions, is if you place a BD cuff, please place immediately an abutment on it. You will get completely different soft tissue situations than covering with just a cover screw and then suture. You will lose your potential for soft tissue. So immediate abutment placement would be perfect if you can do this already from your planning side. It depends on your workflows, depends on how you do implantology. But by using the BD cuff, I'm shifting you now into the situation that you will do more immediate. You will do more defect situations. You would have treated different. And I will shift you more into looking more to soft tissue, how to contour the soft tissue area, and how to treat this and to support this already by the definitive abutment. But coming back to the EBC zone. So, of course, we have the morphology and the material we're using in different zones. And this is the E zone is the one zone you will see where the plug will start first or can attack the crown. And therefore, we need highly polished surfaces. We need more aesthetic surfaces. So this is a completely different surface than the surface on the B zone. So the B zone is something going through the soft tissue, having the task to keep the soft tissue stable, to push and to support. And at the end, we have the C zone. And the C zone is, for us, it's the most important zone looking at the BD cuff implant. And this is something where we want to have something stable. And of course, by using titanium in this area, for example, we can see already that the BD cuff itself, the cuff itself, can be called as a C zone. So it would be interesting, so if somebody of you will be willing to do this, would be interesting to do a comparison study to look the EBC definition by Gomez Meda, and if this could work in a different way with the BD cuff. Maybe we have a D zone or whatever you will call it. And this is something I want to bring into your mind. And to summarize, the E zone, we have function, morphology, and material in every zone, B zone, C zone. And there you will see the materials are changing and the shapes are changing, yeah, because we want to reach something different. And if we look at the C zone, which is very important for us now today in the workshop, is we have straight or concave, and it's made out of titanium, and we need the crystal stability. So we need the stability on the parallel part where I told you that the bone will stay, yeah, the bone will be attached. And this is very important to recognize. And to give you some ideas from the daily routine, you can see this, and we can define now a little bit the ceramics. Of course, the beauty is in the veneered situation, yeah. Even if zirconia today can be made very, very beautiful, in certain areas, we will veneer the situation. Then you have the possibility of the zirconia coloring liquids. And I can just give you the hint. Don't polish the zirconia at this area and then color it, because color will have a different kind of roughness. The color will disappear if you polish it again. So please do it in the status before you put it into the oven, before you make it, the zirconia strong, because then it's one surface, it's one material. And at the end, we have, of course, the polished zirconia, and we have later on our metal zone. So this is a kind of example how you can build up your crowns, and you see the shape of the crown and the abutment, which supports the gingiva and gives the gingiva or the soft tissue space to be there. At the end, when I was young and learning implantology, we did it completely the other way around, and we pushed the soft tissue away, and we wanted to have the same size and same shape of a tooth, like of a crown, like the tooth. So things are changing, and this is the crown in this case. You see how perfectly the soft tissue will adapt to the crown, and you see how the material, we can play with the materials, and we can seed the crown. And now every material, every zone has this task, and we can hide a little bit our metal part of the C zone, and we can hide a little bit the cuff part. And this is very, very important, I would say, to gain soft tissue stability. And if you listen to the ARI webinar, which will take place next week, I guess, I remember, this is even more important with the ARI, because the ARI means if you ask me what is ARI, the name for it's any rich incisor. So that's more for the critical, for the more difficult situations, and especially there, it's very important how you treat the soft tissue and how you lay the soft tissue around. But if we talk about material and we talk about surface, this is very important, of course. But the question is tissue height, tissue thickness. What do we need? Yeah, and I guess we never looked at the things we need in terms of tissue thickness like we do today. And if you look at your failures in the past, we mainly look at bone situations, but maybe we have to look at the tissue situation also. And often the tissue situation explains us more and better how the failure could occur. So coming back to the EBC of Gomez-Meda, you see we have aesthetic stability, we have biological stability, and we have the crustal stability. And this is done, is promoted, or how you say, by the BD cuff, because we have the stability in the bone by the threads parts. So we don't have any problems with augmentation just to cover the threads. We don't have this, which is often a problem with failed implants. Then we have the cuff part. You can choose how long the cuff will be, and it's depending on the defect situation. And you will always have the highest part of the defect, as I told you, on the lingual or the palatal part. And then you can see where's the buccal part and what's the difference. And then you can measure how much cuff you need. And this will stay on the lingual part, and you have to cover the cuff part just to contour, to thicken up the soft tissue. And now we're talking about the secret. We actively thicken up the tissue to get enough for nutrition, to get enough for stabilization of the gingiva. The question is only how thick must the seal be? And that's a good question. And as we look to the literature, nowadays we know it's around 3 up to 4, in my opinion, more 4 millimeters. So we have to gain this thickness. And if you're talking about a normal implant system like Eneridge or Blue Diamond, it's the same question for you. You have to have up to 3 or 4 millimeters of thickness of soft tissue around the implant so that everything stays stable. But in this case, if I'm showing you this kind of new implant shape, everybody is curious and wondering, and this question occurs way much more quicker than on the normal implant, because we need it also for the normal implant. But in our case, if we have the buccal defect, we will cover by the threadless part, so by the machine polished part. We want to thicken up the soft tissue because we want to have stable situations. And there are a lot of articles in the literature, and I just want to highlight some or two. So this is something because people are saying, I have platform switching, everything works fine. No, even if you have platform switching in your implant, or if you do platform switching actively, if the mucosa is too thin, you will create bone loss. So this is a rule we have to follow, and I would say which is much more easier to achieve if you do the BD cuff version. I don't want to be misunderstood. I'm using BD cuff, I would say, in 20% of my cases. In 80% of my cases, I'm doing the conventional implant workflow with Blue Diamond and Eneridge. But that means I don't want to replace everything by BD cuff. But sometimes I want to use an additional, or I want to offer something additional to the patient. If the patient is afraid of augmentation, if the patient doesn't want to have any material inside his body, there are so many reasons why we are not able to do the augmentation. Then I still want to place an implant, and I want to have the possibility to do this. So the next thing is, we know that we need a certain kind of peri-implant mucosa, that everything stays stable and that there will be not a resorption, and there will be no, because of the resorption, then you get a stable situation of the gingiva. I don't want to have this. I want to control the stable situation. So I want to put up the gingiva at the beginning, and I don't want to lose some bone, because the question is always, what's the body reaction if I have not enough thickness? So it's very simple. And if you want to know this, Linkevicius is the perfect person to talk to, talking about this topic, because if we have less, if you have thin soft tissue, bone will resolve. If we have thick soft tissue, bone will stay. So these are rules we know nowadays. We now for the last 5-10 years. When I started in 1997, I didn't knew that. Now we placed the implants. We had just one diameter, several lengths. We had the tubulate Straumann. Horrible. At that time, it was correct. And nowadays we know more. So please respect the thickness of the soft tissue. And by using the BD cuff, you actively will have a look on it, because you will automatically contour the alveolar and the situation, the ridge situation there, to get a perfect transition to the later crown. So that's quite important. The question is, if we don't have enough, how can we increase this area? Of course, you can do soft tissue augmentation, but what is crucial for the situation? The first easy thing is placing subcrestal, because then you can higher this situation, and you create a better seal length. So that's the first thing. But if you're using already a blue diamond or Emergence, you know already the position of the implant more subpressal. The next thing is much more interesting, because if we look into the literature, 2005 already, we got these pictures in this publication, quite, in my opinion, quite famous people. And you saw that they created a concave situation with their abutment on top of the implant shoulder. Because if you do concave, you increase the seal length, you increase more. And we call it, by Megachin, we call it the S type. You can call it as you like, but here in this picture, you see the S shape situation of the abutment. You see a kind of platform switching, of course, but you learned only platform switching doesn't prevent you from bone loss if the thickness of the soft tissue is not enough. So this is important, but by placing it subpressal and by using something like a contour or concave situation of the abutment, you can improve the situation of the soft tissue in addition to the augmentation. Yeah, that's it's always funny if you have new technologies, if you new things, you always think life gets better and the old tradition rules are not important anymore. That's not true. We still have to respect what we learned in the past, and we have to combine it with the new things we have. So that's an important thing I want, or it's an important message I want to deliver, because we still have to do our surgery. We still have to augment, but augmentation is a different way now, because the aim of the augmentation is different. The aim of the augmentation is only contouring. It's not anymore the osseointegration, because the cuff will be osseointegrated on the palatal or lingual side, but on the buccal side, we have the defect. We don't need if we have enough thickness of the soft tissue. So the question is always, the second question beside the question, is the bone on the lingual side adapting to the cuff, or is it resolving? The next thing is, how will the soft tissue behave around the cuff? And that's quite easy to answer, because if you go to paleontology you look there, we have different kinds of fibers. Then you will see that the circle fibers are forming a kind of ring. And that's the reason why we created also these markers, these ring markers at the cuff at the height of 2 millimeters, because this is an anatomical rule, this is an anatomical landmark, how the body will behave around it. And you will get something very tight and sticky. And I asked ChatGPT so far what I'm doing with AI. No, to give me a nice explanation, a graphic about this explanation, and that's it. And I think it's pretty nice picture. Now you can understand how everything is organized around the abutment, and it's tight as long as it's healthy and not infected. Of course, even if the blue diamond is very young, it's a very young thing on the market. Behind the scene, we developed it for a longer time. There were already two studies looking at the behavior of the biological response compared to conventional implant systems. And this was a 1-year follow-up, and this was proving that the systematic is staying stable. The second one was looking at the machine long neck, and I guess this is still a point where we have to look at, and where we have to prove in several studies. Me at the university, we're doing now a study where we want to look at the way you cut if you have not an immediate, if you have a delayed implant, a late implant placement, how we cut the soft tissue. Is there a special way to cut the soft tissue to get an ideal or extremely good response of the soft tissue of the flap to the BD cuff part, to the machine polish part? So you would see there are many studies running at the moment, but as far as I can tell you it's working. And there will be a offline workshop in London. I will be in London in October, and I will show you some more information, and we will talk about how short implants will behave, because often it's the question, yeah, if I only have 5 or if I only have 7 millimeters of thread part and you have 4 or 6 millimeters of cuff part, is this working, yes or not? And how is this the stability is behaving? Well, just looking at the short implants, I'm not a big fan of short implants in general because I learned the augmentation of the sinus, but we learned from the short implants they're working, and there's a, a biological way why they are working. And so we will discuss all these topics. And today I will just a little bit highlight the soft tissue treatment. So you saw this. This is the case before. So we extracted the teeth, we placed the implants, we augmented just for contouring. And we had 1 year later, we had the soft tissue. Now we can discuss if we can improve the different parts of the attached gingiva and movable gingiva. Of course, we can talk about, that's what I mentioned, the flap design and everything, but in general, the systematic with the base, with osseointegration and the cuff part through the defect, healing and getting the soft tissue contoured is working very perfectly. And I guess this is a very important message. And I hope I could underline my words a little bit with the literature already, so that you can see that it's not my opinion, my personal opinion, or the opinion of Dr. Park, and now everything is running. Now that it's scientific based, and that we have really looked at the science to see these things. So if we talk about the seal, and I told you at the beginning, we have to seal the penetration zone. How can we destroy this penetration zone? Or is it possible, or what will happen? And the biggest thing for me is to tell you probing destroys the seal. So this is, I guess, same aggressive statement like the first statement to say, oh, we're using now a new implant system. And if we look to literature again, and it's nothing new, it's from 2018. And if we look to the periodontal departments, biological parameters mean probing depths do not correlate with mean bone loss, and this irrespective of follow-up. So that means if you probe, you can't say, okay, now I got a bone loss, and this bone loss is because of this and that. Don't probe, because probing doesn't mean that it's the same, that you have a validation. So the frequent clinical probing increased mean pocket depths. That's very interesting. And I already recognized this in 2010, because you disrupt the epithelial and connective tissue attachment. So if you have a patient with implants in your routine of the dental hygienist, tell her not to probe. You can probe on teeth, but not on implants, because it doesn't matter if you have a BD cuff or if you have a regular implant. It doesn't really matter. You can watch, and you have different kinds of criteria to look at and not to probe, because then you will disrupt everything with which heals so beautiful and nicely. And these are the pictures. So we destroy everything and every kind of reattachment we can expect between zirconia or titanium and the soft tissue. So visual inspection is very important. Palpation is very important. I would say also X-ray is important. So in our office, we do an X-ray on the implant patient every 1.5 years to control if everything is stable. And if we have a critical person, we do it every year, because we want to control everything. And we don't get a feedback by the soft tissue, by the implant. We get a feedback by the tooth, but not by the implant. So that's the first thing. Don't destroy this, the seal in the penetration zone by probing. The next thing is, and now I'm coming back and turning back to the starting point with the abutments. For sure, you heard one abutment at one time. So if we use the abutment we want to use at the beginning of implant placement, and everything is healing around this abutment, and can stay stable for the rest of the life of the implant, ideally, then it's a perfect thing you can do. And of course, you see, we have different studies where they are associated with if we screw on the implant, yes or not, do we lose something? Also, we have here the one abutment one time by Thomas Linkevich's. These are very important things. You got studies where we see the measurements and we see the marginal bone loss. And here you see the comparison between 3 and 5 disconnection node in the healing abutment. So 3 and 5, you would say, oh, that's not enough. That's a lot. No, it's not, because you screw a lot on your implant during the healing phase because of the reconstruction. And we didn't talk about try-ins already. Yeah. So that's very important to see. And if we look at a very early study, when I was beginning implantology in 1997, Abrahamson and Berglund and Linde, that they already showed us that the findings indicate that this and subsequent reconnection of the abutment component of the implant compromise the mucosal barrier. So this is very interesting, and this results in a more apically positioned zone of connective tissue. That means everything is going down. And with the bone, the soft tissue also shrinks. So that's very important if we can let our abutment stay there till the end. This is a study from 2017, very important. There are nowadays, if you go to PubMed, there are, I wouldn't say millions, but tons, yeah, which are telling you this. And of course, we have also to say that this might be an academic discussion, like this study told us, like at the end, and this, I didn't highlight this, but I have to read it. However, the difference between the groups was minimal. Thus, the clinical relevance of those results is doubtful. Yes, of course, there might be something which still keeps everything, keeps the bone at the implant. It's depending on so many factors, but at the end, if we screw on the implant directly, we will lose something. Or if we look back on our failures, then we can say, okay, maybe I lost not only because of the thin soft tissue, but also of the screwing. And if I can keep the abutment, because nowadays you can bring or screw on your scan post on the abutment, not on the implants, we have these biggest advantages we can get. And I guess these are the intermediate structures should be highlighted more, especially for the all-on-X cases, especially for bridges in cases, and even for single tooth reconstructions, we can talk about this. And for this, I want to just introduce you today also the AXA abutment, which is similar new in the company as the BD cuff. The AXA abutment exists for the blue diamond, for the BD cuff, for the ARI. So you have in your family, you have the same abutment on different implant systems, which makes you which makes it more possible to reconstruct, even if you use different implant systems in one jaw. So AXA abutment is simple to describe. So first of all, we have different angulations. So you have different angulations from straight till 30 degrees. Then we have different heights. So the part where the later crown is, or the reconstruction is fixed on, is always 4 millimeters. But the rest, you see, I hope I could show it quite good with my graphs. The rest can be chosen in different lengths, and this length depends on the different degrees. And of course, we have the different gingival heights. So this is also interesting to choose. So we can adapt this already to our position, to our gingival height. And now you understand why I told you, please, please, please use already the AXA abutment at the time of the BD cuff implant placement, or the blue diamond implant placement, or in the near future in the InReach implant placement, because they are available and you can use them, and you can screw your crown on it, you can screw your bridge on it, you can use it for the for the all-on-X, and compared to the multi units, or the octa abutments. Multi-units is just for multiple reconstructions. You can't use multi-unit for a single crown. You can use octa, but octa and angulation are two things which are not working together. So that's important to see. And if you look tonight or tomorrow in the internet, you're looking for, you Google AXA abutment, then you will see this sheet. It's a nice sheet, but I want to highlight the most important thing on the sheet. So it's designed for strength. So that means you see here the multi-unit abutment and you see the AXA abutment. So we have different options. We can angulate, and of course we have more strength in the screws, because when I did all on X, I always wondered how these little tiny little screws, which can fit into my watches, can keep this 12 or whatever, how many T's in the mouse. So that's something which is much more interesting. We have a more stable post height. The screw has more threads, and I would say that the tolerance, the torque tolerance is nicer. So we have more advantages. And if you look at this, you see that we can screw directly the zirconia crown on the abutment. You don't have to put in an intermediate structure like a metal base to screw it on. So this gives us more freedom of, how to say, of freedom of choice, because sometimes in aesthetic cases or in different cases where the height is missing, we can play a little better with the whole things. So that's a very interesting topic on the AXA abutment, but I guess for the AXA abutment, we should do another course. So, and again, you have also some kind of indication guides. There's a set existing for AXA indication guides, and you can see, where do I have to drill? Where is my angulation? Where is the situation? How much cuff height do I need? And then you can plan during surgery or before. Before, I will show you in a minute. During surgery, it looks like this. Of course, you have to look where to place the implant. If you have a certain kind of gingival height, just not to have exposure, place it a little bit deeper, as I told you, subcrestally. Of course, then you have to look with the drills and the drill lengths. This is something we will do in a workshop. And the same here in the lower jaw. So angulation is possible even with a cuff situation, and then you can correct everything with the degree of your choice of the AXA abutment. This is a case shortly. I will show you just we did. So we had something to extract. We had late implant placement. We had an immediate implant placement. We had a situation where we thought we could immediate place, and then we didn't because there was no chance. And now you see in the AlterGate planning, if I guess you're familiar with that, you see on the right picture, you see how we already plan the angulation of the implant, the position of the shoulder of the implant. We planned the cuff height. We planned the angulation of the abutment. And now you can immediately plan everything you need. And this is for the tooth 4-5. And you immediately see that the cuff height is starting at the point where no bone is covering the implant anymore. So in the thread part is covered by the bone, and you can adapt or adjust your AXA abutment according to the planned situation of your later teeth or later crown. And this is, for me, this is modern implantology. I wouldn't, well, modern means like future. No, I would say this is the implantology, how we should do it today. Yeah. And on the left slide, you see directly the resorption of the bone on the buccal side. And this is where we're going to do the implant. And now you can see if we cut in a wise way and we do a good flap, we can easily augment immediately the buccal part around the placed AXA abutment. And I guess this is something I want to highlight, that this is very important to see, that this is where we play implantology in these cases. Yeah, same here. Yeah, and then you can see, okay, this is a blue diamond implant because I have no need for a cuff, maybe, yeah, because I can place it deep. But I can, even there, I can combine blue diamond and blue diamond cuff with the same abutment. I'm using the AXA abutment. I use a kind of height, I use a kind of angulation, and I can later on screw everything. And this is how we decided. We started, of course, with 4 implant, and then we decided just to place 3 for several reasons, and to make a cantilever to the mesial part, which is possible. To the distal part, I wouldn't recommend, but to the mesial part, it's not a problem. And now you can see what we planned, and everything can be transformed or translated into the guide. And then you can place your implant with the guide. It's quite simple. And this is something my lab technician did for me. Um, he did the planning for the temporary without having the implant placed already in the bone. And this is how we tried to design everything, and how we tried to design the temporary. And even the temporary you can fix on the structures. And this is how this is a printed, it's not a milled, it's a printed temporary. And this is how we're working with it. And now you can see the AXA abutments fitting into the situation, and you see the angulation, you see the position of the crown. And because everything is pre-planned, we can go for that. So this was a very quick ride through the whole topic. If you want to cover more, or if you want to cover the whole story, 9th of October in London, we will have this beautiful workshop training, whole 1-day training. And there, I guess we can answer all these questions on prostate, on bone, on soft tissue, compared with other things. And just take a photo of the QR code, and then you can book this. I would love to see you. And if you want to get in touch with me, it's no problem. You got the choice of 2 emails. One is from my university, one is my private from the office. And would love to see you at the workshop or somewhere around on the congresses of Megachan. It was a pleasure. And now I'm gonna hand over to Hassan, I would say.
All right, sorry for the technical issues, guys. I won't keep you long. As I said, my name is Hassan Megera from Leeds. I'm a clinician, just like every one of you. I'm also involved in bird education. And you know, if you look at my background, I'm an oral surgeon or interested in oral surgery, and usually I do lots of lectures worldwide on bone grafting. But last year I was invited to go to South Korea, and I was lucky to be trained by Dr. Park on the use of Megagen Blue Diamond Cuff, which has definitely changed the way we practice. I'm not saying that we don't do grafting anymore. Obviously, we do it, but we start to be more selective. And whenever we got patients who cannot tolerate grafting, BD Cuff came as a good answer. So I will share with you 3 patients and where we had to, or we chose to use BD Cuff. My first patient is Fatma. Fatma is a Turkish lady referred to me by her dentist for implant placements on the lower right 6, lower left 6. There was a little note attached to the referral that patient is not keen on bone grafting, definitely doesn't want to go through staged bone augmentation, and patient is not interested, or she wouldn't like to get any porcine products. Both teeth were extracted a while ago. So once she came into the clinic, we took CBCT, intraoral scan, and we started doing digital planning through R2 Gate. And as you could see, the case was quite advanced atrophic ridges. We've got a range of 2.5 in the lower right 6 and a knife edge on the lower left 6 to 4 millimeter. And in the past, I would go to Fatima and say, sorry, the only way is to do maybe Curie plate, bond block, sausage technique, Novamag plate, and then come back after 24 weeks and place a dental implant. But luckily for Fatima and for myself, we decided to treat this extensive buccal bone loss and this atrophic ridge using a BD cuff implant. So this is her lower right 6. And if we were to go for a blue diamond implant, like a normal dental implant, as you could appreciate, putting the implant in the right position, we will end with exposed lingual and buccal threads. However, as we considered BD cuff, you could see we're using a 4.1 diameter implant a 5 mm threads with a 4 mm polished cuff. That did the trick. We knew from the start we're going to get lingual and buccal defects, but because of the polished collar, as Marcus mentioned, you get some good bony but also soft tissue attachment. So this is the difference between using a normal BD implant versus a BD cuff implant for the same case. So remember, Fatma was not really keen on using any biomaterial in this case. So this is how we started. We did fully guided, and we drilled in the ideal prosthetic position. And as you could appreciate, as we expected, we knew we're going to get some labial defect. But using BD cuff implant with a 4 mm cuff, as you could see, I wasn't so worried about that because we've got the polished cuff, we've got the grooves, and all the treated threads were inside the bone. So basically, this case was a straightforward implant placement, and we decided just to keep it simple. We managed to get stability more than 25 Newton centimeter. We put transmucosal healing abutment, and after 6 to 8 weeks, as you could appreciate, we've got nice healing, nice soft tissue, and good attachment, and as Marcus mentioned, even better, good soft tissue seal. We took a digital scan, and you could appreciate the emergence profile created just by having a nice healing abutment, and then we restored it with a straightforward crown. Fatima started to gain some trust, and she realized implant dentistry is not that complicated. So we decided to go and move to the next side. Now, the next side was a bit more atrophic, and I told Fatima that usually this case will require stage bone grafting. However, we're going to keep it simple, place a BD cuff implant, knowing that we're going to get not only exposed soft tissue collar, but also some threads. But most of the implant, if it's placed in the right position, will be within bone. And we will just need a little bit of guided bone regeneration to contour the ridge and cover the exposed threads. So rather than going for atrophic ridge management using bond block or sausage technique or Curie technique, we're going to go for straightforward GBR in this case. But remember, Fatima did not want to have any porcine membranes, so we came out with another membrane. So this was placed back in January 2026, and this is a fully guided implant placement. And as you could appreciate, this is our BD cuff implant. Implant placed to the mesial and distal peaks, maintaining a minimum of, I'd like to keep it 2 to 4 millimeter soft tissue thickness. And from there, we've got our Novamag membrane, which is a membrane available in the United Kingdom through Megagen, and use that magnesium rigid membrane, which is still self-resorbable. So it's rigid, synthetic, self-resorbable. And we use the magnesium grade 5 screws to help us to support the membrane. We created the box, and we created a buccal jumping gap of 4 millimeter. And then we went through the stage approach, grafted with allograft first, and then the outer layer, a mixture of allograft and xenograft. And then from there, we just covered it with a membrane, and then we stitched and covered everything nicely together. Now, we buried the implant just for the GBR. After 6 to 8 weeks, we did the exposure, and at the time of the exposure, we thought we might as well correct the keratinized mucosa. So we harvested a free gingival graft, and we depithelized the bed, and we stabilized the free gingival graft, which we harvested from the palate. And then you could follow the Ricardo Kern technique, where you etch, bond the palatal cusps of the top teeth near the graft area, and then put flowable composite just to put some pressure and get you some hemostasis. From there, we stabilize the free gingival graft around the polished collar of our blue diamond cuff implant, knowing that the grooves in the BD cuff gonna help us to get good seal. And from there, after soft tissue healing, we went on and restored the case with another screw-retained titanium, screw-retained CAD-CAM abutment with a zirconia crown. But the beauty here, I knew that my BD cuff will get me some good bone integration, but also some good soft tissue attachment. So I wasn't too worried about having tiny bit of bone loss around the BD cuff implant. Now, if you want to know more about the Novamag membrane, I'm coming to Glasgow, 26th of September. Megagen is organizing a one-day workshop and seminars on the Novamag membrane. And if you want to know more about the soft tissue grafting, I'd like you to consider the course we're running in Leeds on the 9th and 10th of November, 2-day masterclass on all aspects of soft tissue grafting, whether it's CT or free gingival graft. But let's move quickly to our next case. Our next case is a lower full arch case for Nafisa, an old lady who came in referred to have a full arch fixed restoration. Now, again, Nafisa is a nervous patient, and we decided to try our best to keep everything minimally invasive. And I chose to go for BD cuff in her case for different reasons. If you look at the reasons why I decided to go for BD cuff, one of the implants was very close to the nerve. So I decided to go and place it slightly supracrystal to allow me to be away from the mental nerve. But I wasn't too worried because the polished part is going to be the supracrystal. Another implant will have a very thin buccal wall if I place it in the ideal prosthetic position. But again, I wasn't too worried because that polished part is going to be covered with very thin wall. And even if that wall decides to remodel in the future, I'm going to get very good soft tissue attachment. Another one, thin lingual wall, again, not an issue. And again, knife edge ridge, not an issue with BD cuff. So as Marcus showed you, we would use R2 gate. And on the R2 gate library, you could choose a BD cuff. You could even decide on which AXA abutment you want to use, whether straight or angulated, based on the digital wax up, the emergence profile for your case. So we do the reverse treatment planning, step down technique. And as you could appreciate, you could even decide whether to use BD cuff with 2mm cuff or 4mm cuff and which length of the implant. We use the R2 gate guide and we use the stabilization pins. It was a stackable guide. You stabilize the guide, then using the current teeth, remove the top part and do the extraction as you decided with your patient. And then from there, you could do degranulation bears to clean the socket. And then you fit the second part on the base and you start placing your dental implant fully guided. And in this case, we knew if I stick to my BD cuff implants using the same principles of Megagen, fully guided, I have the green line, I have the black bands, everything guided for me. It will allow me to place the implant in an accurate position, not worrying about future bone remodeling, which might cause exposure of the rough threads and risk of peri-implantitis. From there, we even had a stackable guide, the third part of the stackable guide with a ready-made temporary bridge. And here are the implant placement, and then fitted the AXA abutment as planned, and then we decided to use these temporary cylinders. We could have gone for straight from the temporary bridge to the AXA, but I decided to go for these temporary cylinders so I can check passive fit and add strength to this PMMA temporary bridge. And then from there, we use the stackable to help me to convert or attach the cylinders to my temporary bridge. And we polish the bridge chair side, and we've got a nice full arch temporary bridge on my blue diamond cuff implants, different heights, different cuff heights, with my AXA abutments and with my temporary bridge fitted in place. And this is the healing after 2 weeks. The same patient had a similar case using the full arch treatment for her upper jaw using blue diamond implant with AXA. And then you could see, for me, it was a straightforward surgery, less sweating surgery because of the magic of BD cuff. I didn't need to worry about bone shaving in this case. I didn't need to worry about bone grafting in this case because everything was calculated and I knew my rough threads are covered within thick buccal and lingual bone. And these are the AXA abutments. And if you look at the X-ray, we have these click-on grooves, which will help you to see whether these cylinders are fully passively seated on your AXA abutments or not. Now, the plan is now to refer to my prosthodontic colleague who will finish the case. But if you want to know more, as Marcus mentioned earlier on, we have a great opportunity here in the United Kingdom that Marcus is coming in October, on the 9th of October, full day on BD cuff and AXA abutments. And I think this is a great course you don't want to miss. Let's move to our third case. And it's an interesting third case because Lucy was planned and designed to have a 3-unit bridge, lower left 5, lower left 7. And the initial plan for me was to go and manage this atrophic ridge using BD cuff implants. That was the original plan. We raised the flap, identified the mental nerve, and as you could see here, that's a CBCT. It's a knife edge ridge, but using the BD cuff with a 4mm polish cuff, I knew that my rough thread's going to be within thick bone. So it wasn't an issue. Now, the plan for the 7, it was a bit more atrophic, and the plan was to go like that, and then maybe a bit of GBR. But I've consented Lucy to do a trial in this case. We decided to use BD cuff on the 5 and do stage bone grafting for the 7, and later on place a dental implant after the stage bone grafting. And because we decided to go for stage bone grafting, we went and did the lingual flap elevation, mylohyoid muscle detachment. And then we decided to use the Novamag magnesium rigid membrane and using some allograft from Botis, which is distributed in the United Kingdom by Megagen. And then we stabilized the Novamag. And after the decortication of the buccal plate, which was very thin ridge, we decided to fill it with the allograft and then cover it with a collagen membrane. And we decided to leave that 7 for 6-month healing time. Now, for the 5, we decided that we could go safely using a BD cuff implant without compromising the prosthetic position. And we place a BD cuff implant 5mm height with additional 4mm cuff, and it's a 4.1 width. We managed to get good stability, put transmucosal healing abutment. We did some ridge contouring this time, not to graft and get osseointegration of the bone, just to do ridge contouring to make it easier to restore later on. And then left it 24 weeks healing because we wanted to wait for the allograft to integrate really well. And after 24 weeks healing, we did the R2 gate digital planning. And as you could appreciate, we went from 2 to about 7 to 8mm thickness. But now I could use a straightforward normal BD implant. I don't need to use BD cuff. And you could appreciate from the R2 gate digital eye, we've got really nice solid bone in that area. Because in the R2 gate digital eye, yellow, blue, and anything above is considered solid bone. So that's the before planning and that's the after planning. And you could see, yes, I could have used BD cuff, but Lucy kindly agreed to just do this study case for her as part of the academy and do a bone grafting and use a BD. And that meant extra 6 months, but she was okay with that. And we are, this is the time of the exposure. Now, interestingly, while the membrane itself dissolved completely within 16 weeks, the screws are made of grade 5 alloy. So even after 24 weeks, part of it was still there, but it was mostly like 75% resolved. You could appreciate the difference, and you could see how we grafted that. Again, if you're interested to know more about this and have some hands-on training, Megagen and Baird Academy collaborate, and we run this masterclass twice a year. Our next one going to be in 22nd, 23rd of January in Leeds, where you will get hands-on training on all these techniques and the different indications of the magnesium membrane. So now we have enough bone to allow me to place 4.1 by 7 millimeter blue diamond implant. And we decided this time to follow Marcus' recommendations and go for the AXA abutment on the day of the implant placement, because by then we will not need to interfere with the implant connection or disturb that C zone around the dental implant. So the beauty of the BD cuff, not only that it's offered at the same price, which is a great thing. It's an upgraded implant, but you could buy it from Megagen for the same price of the BD implant, but also it has the same prosthetic platform. So the same drills, the same screwdrivers, the same healing abutments, and the same AXA abutments. We fitted the AXA abutments and we put some healing caps, and now we are in the process of referring this case to be restored by my prosthodontist with a 3-unit bridge. As I promised, this was a quick overview of some of the cases we've treated at our Leeds Dental Implant Cosmetic Clinic in Leeds using BD Cuff. We've got more ongoing cases, and the take-home message that it's not about what you and I can do. It's about what's suitable for that specific patient. And some patients, they will be put off if you offer them stage bone grafting or advanced augmentation. Now, Megagen also introduced or launched another very clever implant called RE implants. And this implant will be very useful for knife edge atrophic ridges, especially in the maxilla. And I'm very delighted to announce, as Alga mentioned, we're going to have a very good webinar next week offered by Dr. Youssef and Dr. Rokas next week on this very specific implant. Now, if you allow me to just finish this presentation by inviting you to our International Congress in London on the 6th and 7th of November, where we're going to celebrate our 15th year anniversary of our Baird Academy. Megagen is going to be our platinum sponsor, and I'm very honored that Dr. Park himself will be one of our key opinion speakers or keynote speakers. And for you guys on this webinar, if you scan this code, you could come and join the Congress, benefiting from the 50% discount if you join today up to 24 hours from now. Once again, I would like to thank Alga for the kind invitation and for organizing this webinar. And I'd like to thank you all for joining us and, allowing Marcus and I to talk to you about BD Cuff and our experience with BD Cuff. Thank you so much, everyone.